Welcome once again to another webinar series from the AFRH. I hand you over to Mrs. Onipi Uja Samuel to do the housekeeping rules. You're welcome. Thank you. Mrs. Onipi Samuel Uja, over to you.
Good evening, everyone. Like we all know, my name is Onipi Uja Samuel, and I'd like to say thank you again for joining the last edition of our bi-monthly webinar series. And of course, marking that for this very embryology series, many more things to come eventually. But for the embryology series, this is going to be the last edition. So going straight to the announcement before the big presentation for today, the second Congress of Africa Federation Fertility Society, AFFS, holding alongside the 16th Association for Fertility and Reproductive Health, AFRH, the annual international conference, team AFFS Abuja 2026, will be holding on the 24th to 26th September 2026. And the theme is Fertility Frontiers, Global Innovation and Advances in Human Reproduction. And the venue is Abuja Continental Hotel, FCT Abuja, Nigeria. So for more information, kindly check the flyer on our AFRH platform for full details. Then, of course, participants are expected to register for the conference website, www.affsconference2026.org. Our early bird discount closed long before now. And of course, the abstract submission, something great happened. There's been an extension from now to the 15th of this month, July. Abstracts are still can still be submitted. So from now to 15th of July, if you still have your abstract and you really want to do a presentation because of the conference, do well to submit your abstract before 15th of July, 2026. Then, of course, we expect everyone to please follow AFRH on our website, on all our social media platforms. And then, of course, we have a whole lot of information rolling out part-time over there. So if there are things you want clarification for, all you have to do is go ahead and install our app, and then you'll be informed. For today's presentation, we have Dr. Kiola, and we know it's going to be a big wrap for this series. And for you to remember, this very podcast is going to be recorded, and you can actually visit the AFRH app for you to get an information or get a replay of this very program. And okay, so that's it for the presentation announcement. Over to you now, Mrs. Lana. And please do remember to put your Q&A, your questions in the Q&A box. Over to you now, Mrs. Lana.
Okay, good evening once more. Our speaker for today is Dr. Lateef Akinyola. Dr. Lateef Akinyola graduated from the University of Ibadan, UI in 1985 with MBBS. Since then, he has trained in Nigeria and abroad to earn an MSc in Human Anatomy / Embryology, University of Lagos, a PhD holder in Molecular Reproductive and Endocrinology, University of Oa, Finland, where through his research, he coined the gene responsible for estrogen metabolism in human and research animal. He is a fellow of the Royal College of Gynecologists, England, and fellow of Royal College of Gynecology, Royal College of Obstetric and Gynecologists. He also got an MBA in Health Services Management from the University of Plymouth, England, to sharpen his health services management skill. Dr. Lateef Akinyola is a distinguished obstetrician and gynecologist, reproductive medicine specialist. He's a tutor of tutors and an undergraduate or postgraduate teacher in various hospitals, home and abroad. He's an adjunct associate senior lecturer and seasoned senior research fellow Department of Obstetric and Gynecology, College of Medicine, University of Lagos, Lagos State, Nigeria, and a senior research fellow at the Center for Clinical Trials, Research and Implementation Science, University of Lagos, Lagos State. He trained in the London Deanery and has worked as a trainee and consultant at St. Bartholomew Assisted Conception Unit, Royal London Hospital, Newham University Hospital, Luton, and Dunstable Hospital, the Pontbury Fertility Clinic, and the London Women's Clinic. While working in this hospital, he gained advanced specialist interest in obstetric, gynecology, minimal access surgery, laparoscopy, and hysteroscopy, and fertility medicine. He has a keen interest in molecular biomedical research, especially in ovarian sterogenesis and follicogenesis, as it pertains to assisted reproductive technologies, ART. His clinical research interests also encompasses endometriosis, adenomyosis spectrum, recurrent miscarriages, fertility optimization, polycystic ovarian syndrome, and high-risk obstetrics. He has published extensively clinical researches interest in high-impact journal. He is happily married with children. He presently practices in Lagos as a consultant obstetrician and gynecologist, reproductive medicine, IVF specialist at the Medicine Specialist Women Hospital, Lekki, Lagos. He's a member of the Executive Council of the Editor-in-Chief of the Society for Gynecologists of Nigeria, Lagos sector, and AFRH. He is also a member of the British Fertility Society, European Society for Human Reproduction and Embryology, ESHRE, and the American Society for Reproductive Medicine. I hand over the mic to Dr. Lateef Akinyola to give us his insight and from his wealth of knowledge on fertility preservation. Thank you, sir. You're welcome, and good evening, sir. Thank you.
Yeah. Thank you so much, Mrs. Uja and Mrs. Rifkat Lana. I thank you, my organization, my association, AFRH, and the Executive Council for giving me this opportunity to give a webinar talk on fertility preservation, options, and outcome. Let me share my slides, please, so that we can start promptly. Can you see my slide, please?
Yes, sir.
Okay, so let me
It's
put
coming
it.
up.
Okay, so is there now?
Okay. Yes. Yes.
Okay, so today's topic is fertility preservation in ART, options and outcome. We're going to, talk about this, very, very important topic in ART, and as we know, it's a key pillar in reproductive medical options. We'll talk about its outcomes and recent updates. My agenda for today will mention briefly about infertility scourge that is around the world. We all know about this, so there is no new knowledge to share in that. We'll also talk about cryopreservation mechanism and pathophysiology, indications in children, men and women, patient selection and treatment criteria, advances in vitrification and laboratory techniques. We also talk on the ethical, social, and religious and legal considerations, and we will mention, some knowledge about real-world cases outcomes. The global burden of infertility, we know that in the world, there is about 17.5% of adults that are infertile. That's ratio 1 to 6 couples. So giving us about 186 to about 200 million in the whole world. And to date, worldwide, we are doing about more than 3 million ART cycles annually. And yet, the average live birth rates rarely exceeds 30 to 35%. This declines sharply as we get older in age, what we call the age factor in infertility. And this is additionally compounded by disease like malignancy and environmental and lifestyle inhibitions, smoking, alcohol, recreational drugs intake, and all that like that. And we also have some, career-minded individuals, male and females, that for prosperity or awaiting Mrs. and Mr. Right to come forward. And this clearly enforces them, as some of these individuals go into 37 years or more, especially the females, and make them to defer parenthood, lumping them into voluntary infertility cases. The quest for fertility preservation has thus increased worldwide. Now, what is fertility preservation? Simply, we can say that is the use of medical and laboratory interventions to preserve reproductive cells, tissues, or organs before fertility is impaired, enabling individuals to retain the possibility of future biological parenthood. Fertility preservations, what are the indications? In the female gender, let's start from girls or even fertile women diagnosed with cancer. So fertility preservation is recommended or advisable for them because they would shortly before their treatments, including gonadotoxic chemotherapy, which will, of course, be toxic to their reproductive potential. So they will be advised to, go for fertility preservation prior to getting gonadotoxic chemoradiotherapy. And then we also have what we call social egg freezing in the past. Is now planned oocyte cryopreservation for those of our community or members that are career-minded, and they rather finish their PhD or whatever before they get into marriage, delaying their parenthood status. There's also, this technique that is, newer, so to say, the freeze-all strategy. Is also a form of fertility preservation, especially to lower the risks of OHSS. So as we know that anytime we do IVF cycles for our patients, most of the time we have excess embryos that we can freeze for future frozen embryo transfer. It's also a sort of fertility preservation. And we have a lot of medical reasons: immunoglobulopathies, HBSS, also severe endometriosis patients going for surgery or preparing for surgery, premature ovarian failure, autoimmune diseases, and variety of genetic and ovarian insufficiency risks, fragile eggs, Turner syndrome, X chromosome, and transgender individual that will be, taking orchidectomies or ovarectomies. Before they do this, they may be advised to do fertility preservation. In males, cancer also takes the major role before chemoradiotherapy. And people who are going for vasectomy, sometimes they may want to preserve their fertility for future change of mind. HIV positive individuals, before the disease, becomes very severe. Gender reassignment prior to using feminizing HRT or orchidectomies, and then planned semen crowd storage, in more or less like what we have in the social egg freezer. Posthumous indications are also there. A man had an accident, and before the body so degenerates to the extent that it becomes ready to be buried, sometimes they may want to harvest or testicular tissues for fertility preservation. So there's a wide range of opportunities and indications for that. We also have cryopreservation preservation as the technological backbone of fertility preservation. And what is cryopreservation preservation? It's as simple as saying the process of freezing cells or tissues and depositing them in liquid nitrogen at minus 196 degrees centigrade. This temperature is not a physiological condition for cells and tissues or organs as we know. But to make this possible, we do add some cryoprotectants, some chemical molecules that makes it beneficial, so that at the end of the day, when we thaw the frozen gametes or embryo, we will achieve significant post-thaw functional rates. Fertility preservation or cryopreservation essentially is not a new thing. It's been on for centuries gone. But in 1949, a pivotal system was established by Polge, who discovered protective properties of glycerol for human sperm freezing. And this was taken forward in 1983-84, when using this method and slow freezing, the first human pregnancy was announced, proving that multicellular structures, tissues, or even ordinary cells can survive cryopreservation. 1986, first pregnancy from cryopreserved human oocyte was reported. 1999, a paradigm shift, the first birth from vitrified oocytes. Before this time, in the late 70s and early 80s, oocyte freezing was still very much experimental. But from 1999 onward, it becomes part of the armamentarium we use in ART for fertility preservation. And in 2004, the frontier expanded, and Donex reports first live birth from autotropic transplanted cryopreserved ovarian tissue. What are the objectives of cryopreservation of any animal tissue, gametes, or organs? Is more or less to arrest biological time, that is to arrest any physiological functions, to preserve cellular integrity. And how do we do this? We'll talk about this as we go on. We all know the physics behind it, or if we can quickly, glance through literature for more detail on the physics of cryopreservation. But one thing that is very clear is that when we put a gamete or any tissue or organ at sub-zero temperature, when it gets to minus 132, it enters suspended animation. What do we mean by this? All the intracellular liquid becomes glass-like, and this preserve or stop any physiological function or metabolic functions of the cell until we are prepared to thaw it and bring it back from the suspended animation stage. Cryoprotective agents are necessary. They are essential, for the success from cryopreservation to post-thaw and to then use the gamete organ or tissue. Cryoprotectants we have two major types of cryoprotectants. We have the penetrating types and non-penetrating types. I think that before we go into, nitty-gritty about ART, let's know a little bit about what is cryopreservation on its own. We have a lot of cryoprotectants, as I mentioned, penetrating and non-penetrating. There is glycerol, which is penetrating, DMSO, dimethyl sulfoxide. It's also a penetrating, they are both penetrating low molecular weight. While glycerol is used mostly for cryopreserving, especially sperm, it's a molecule that gradually, when introduced into the media with the gametes or embryo, it gradually slowly enter through the cell membrane into the intracellular milieu, displacing water. It's non-toxic even at high concentrations compared to DMSO, which is highly toxic in higher concentrations. Both of these molecules give rapid intracellular protection, and they stabilize all the intracellular macromolecules. We have others that are non-penetrating, especially hydroxyethyl starch. Glucose is one of them. These molecules, they are mostly hydrophilic, with hydrophilic attachment to their molecular backbone. They don't enter through the cell membrane because of the ionic ions they carry. So they stay outside the cells, and also because they are very high molecular weight, they attract diffuse water from the cells, so thereby dehydrating the intracellular environment. They are generally non-toxic, and they provide a lot of extracellular freezing protection for the tissue or gametes that we are freezing. Occasionally, because to avoid toxicity of the penetrating cryoprotective agents, we do mix non-penetrating and penetrating cryoprotectants in order to reduce their toxicity level at higher concentration. What is the pathophysiology of cryopreservation? We know, as I mentioned earlier, CPA or cryoprotective agents are beneficial whether you are using slow freezing or vitrification methods. Cryopreservation, especially with the addition of cryoprotectants in toxic concentration, like 4 millimoles and above, they can cause thermal or osmotic shock to the cell tissue or gametes embryo oocytes, and they can induce alterations in the integrity and physiology of the gamete follicles or embryos. All these can affect the metabolic potential of the cell, and if adversely affects this metabolic cellular physiology, it can lead to apoptosis and cell death. It also causes a lot of genetic degeneration, mitosis, meiosis spindles, degeneration, and all these can cause genetic or epigenetic physiological dysfunctions in the cell. If we apply cryoprotectants in abnormal concentration or low concentration more than what is needed physiologically. All this can happen. So in order to avoid be able to afford a sensible and functional post-thaw gametes or embryo at the end of our fertility preservation journey, we need to reach a thermodynamic balance. And what do I mean by thermodynamic balance? You want to balance the toxic effects of your additives, cryoprotectants, to the benefit, compared to the beneficial effects. So you don't want the toxic effect to be much more than necessary. And in fact, it could be even much more better. The protective effect will be much more better than the deteriorative effect. So in order to achieve that, we prefer to mix penetrating and non-penetrating in, sub-toxic level so that we can achieve a better results post-thaw of the organ or tissue that we are cryopreserving. And this, coupled with the fact that we are using a very, very high cooling rate. We are talking about minus 10,000, a drop of temperature up to minus 10,000 degrees centigrade per minute. And it could be even much more. So this yellow bit summed up the required optimal conditions to do our cryopreservation. That is vitrification with high cryoprotectant agent concentration plus ultra low cooling. Less than 2 seconds, you just plunge your specimen or sample into the liquid nitrogen, after prior preparation with the cryoprotectants and the likes. So we have 2 methodologies to do this. I'm sure our embryologist in the AFR knows a lot more about this. We have slow freezing, and we have vitrification. Vitrification is what is used mostly now because it's been adjudged as the best out of these 2. It gives a lot of more protection to the cell, avoid ice crystallization, and maintain a relatively physiologic amorphous glass-like solid condition intracellularly. So, and then coupled with the fact that we are rapidly plunging the specimen into the liquid nitrogen at minus 196, there is little chance of ice crystals, whether extracellularly or intracellularly, to damage our cells or organs, and thereby also chemical toxicity from the high concentration of cryoprotectants that we use when we do vitrifications are almost eliminated. So vitrification is the in thing now. The vitrification mechanism, consists of a number of steps that has to be taken precisely to avoid any damage. We first of all need to equilibrate our specimen in cryoprotectants to diffuse out or effuse all the water molecules in our cells. After that, step 2, we put our specimen into vitrification solutions and then commence real cryoprotection for our for our gametes or cells or tissues. And it's better using microvolume carrier in plasticware or glassware that we're stepwise going to plunge straight into the liquid nitrogen to avoid, as I mentioned, the danger from extracellular or intracellular ice crystals. There are a lot of cryo devices and choice of systems to decide which is best for your gametes or for your embryo or for the tissue you want to cryopreserve, like ovarian or testicular tissue. We have the closed and open system. They all have their pros and cons. the closed system, and the idea here is that the cryo tip high security straws that are closed system will avoid any contamination, viral contaminations, bacterial contaminations from the liquid nitrogen that you are plunging your specimen into, because the specimen cryo device container is closed, so it's not exposed to liquid nitrogen. This also has its own disadvantage because sometimes the temperature will not reach the core of the closed system. And we have the open system, which, increase the speed of drop in temperature up to 683,000 degrees centigrade per minute. And not all countries, subscribe to this type of open system. And like in France, it's banned. And however, it's been shown that whether you use closed system or open system, there is very little significant difference in outcome. Cryopreservation of reproductive tissues and cells. Let's look into detail. First, we want to talk about sperm cryopreservation. There are a number of indications in boys and men. The risk here is that there is a very high risk in cases needing gonadotrophic treatment. Pre-treatment priority, we need to prioritize what we are doing before we start our gonadotoxic treatment, which can lead to post-treatment azoospermia. It's advisable to freeze sperm, seminal fluid, in men or any post-pubertal adolescent that can, ejaculate and give us sperm sample, or in children that are, or in boys that are pre-pubertal, we likely going to use testicular biopsy to freeze. However, what is found in the real world, we will talk about more about this later on, despite high viability of whether testicular tissue or this seminal fluid, usage after cryopreservation is not very encouraging. And there is a lot of abandonment of cryopreserved sperm or testicular samples. And this gives the organization, hospitals, or even NHS a lot of costs lost, especially cost of storage if the specimens are abandoned. And then that might also lead to what do we do with samples that you cannot contact the owner? You write letters, you ring, you send emissaries, incontactable. So what do you do with the sample? You throw it away, or you continue to cryo store it and incurring more costs for your organization. Because of, in Lod, Lagos, Nigeria, in 1989, a big event happened following the birth of the first IVF baby in Nigeria by Giwa Osage and Ashiru. And this, because of the success of their process, led to a big demand for the service, IVF service, that's in the late 80s, early 90s, by a lot of stakeholders, patients coming to look, seeking IVF treatment. The demand was so high that we cannot, meet up to. And then it was decided that we need to carry out a research how to freeze sperm and embryo in the departments, because we have some excess embryos. Some people are coming from abroad. We need to freeze and cryo-store their sperm for future usage. So that formed the basis of my MSc, Master of Science degree at the Department of Anatomy, College of Medicine, University of Ibadan, under the supervision of Professors Ashiru and Giwa Osage. And we were able to show that using 7.5% glycerol produced better storage out of all the myriads of cryoprotectant agents that we tested. And we also found out then that there was nothing like vitrification then. Everybody was using slow freezing and um, using an engineered freezer, electric ultra-low freezer, minus 90 degrees, before we plunge the sperm sample into liquid nitrogen. We were successful to be able to cryopreserve some of these uh, sperm seminal fluid analysis from our patients. This, happens to be the first time in Nigeria, maybe West Africa, that we are going to establish this process of cryopreserving sperm for later use by our patients. Now, let's move on to oocyte cryopreservation. Success in oocyte cryopreservation is heavily governed by intersection of age and oocyte yield. I mean, as we know that the older a woman becomes, the less possibility of getting appreciable quantity of normal eggs, euploid oocytes. So that shapes the success of the process and the probability that after age 35, the success of the cryopreservation process, becomes highly unfavorable because of high probability of aneuploidy in women that are 35, 36, 37 and above. So it's advisable that to get optimal yield scenario, that is at least approximately about 15 to 20 M2 oocytes, mature oocytes, we should be in less than 35 years of age, as you can see here, 50 to 70% baseline of success. So that means we should be aiming to 15 to 20 M2 oocytes. As the age drops, the number of probability declines, and at more than 40, 15 to 20%, leading to higher rates of aneuploidy and the process become limited, of limited benefits. There are limitations to oocyte cryopreservation because most of the ladies that would come, either there is no Mr. Right available at that time, they just want to freeze the eggs for later use. However, the best chance could have been if they are going to freeze embryos. But to freeze embryos, you need a sperm donor or a donor, a husband or fiancé. So because of this, that it requires sperm donor prior to cryopreservation might be a big hurdle for some of these young ladies. And then there are also a legal conundrum. You freeze your oocytes, then upon divorce, what happens to your oocytes? What happens? Who claims it? So is there a consent form? Or if the man now says, because we are married, I will have access to the oocytes, all this needs ethical, social, and legal conundrum steps to overcome. And then freezing oocytes alone has a higher attrition rate compared to embryos. Then we also need to compare old age factor, infertility, and posthumous use at the same time. There may be need to freeze oocytes or ovarian tissue urgently in someone who was suddenly diagnosed with higher stage malignancy, and that we need to start treatment maybe in the next 1 or 2 weeks for good prognosis. In such cases, we may have no choice other than to freeze ovarian tissue biopsied, or to quickly start their treatment, irrespective of their cycle length of day of cycle, in order to meet up for their treatment requirements. In children, it is preferable that we use ovarian tissue cryopreservation, especially those who are prepubertal. They are not menstruating at that point in time. But in anyone that is postpubertal, we can freeze the ovaries, ovarian tissue, or we can also stimulate their ovaries, to collect a lot of oocytes, maybe more than 15 or less, to freeze. To freeze blastocyst is a special case because blastocyst, as we know, there's blastocell, and then blastocell contains a lot of water. And if you leave these aqueous solutions in the cell, in the blastocyst, it can lead to a higher rate of ice crystal in the blastocyst, which can damage most of the organelles, can also cause damage to the trophectoderm or even the cell mass, leading to apoptosis of the cells and death of the blastocyst itself. So it is advisable to either use laser or other means to puncture the trophectoderm to reduce the water content prior to cryopreservation. Ovarian tissue, we talked about it, is a unique type of thing, but mostly available for those prepubertal girls that have urgent need to cryopreserve protect their future parenthood. And in this case, tissue samples from the ovaries are taken and they are frozen, according to protocol steps. Worldwide, about 200 live births have been born, and the limitations with ovarian tissue cryopreservation is that the risk of reintroducing malignant cells, especially in leukemia, is still, relatively very, very low, but it cannot be minimized to zero. So we have to devise a special protocol when we are going to do autotropic transplantation of the ovarian tissue. As I mentioned, ovarian tissue cryopreservation is the only option for prepubertal girls with cancer because it avoids the risk of stimulation of estrogen-sensitive cancer, number one. It's suitable in autoimmune diseases, social freezing, risk of POF, premature ovarian failure, Turner syndrome, transgender males, and then, of course, it's a specialty on its own, and it needs a dedicated, experienced embryologist to do this, to maintain the morphofunctional characteristics of the ovary. The ovary contains a lot of cells, not only the follicles or the primordial follicles or oocytes. It contains fibrous tissue, it contains other cells, thicker cells, granulosa cells, whatever, and all the other connective tissue cells. So it's difficult to, pinpoint or manage cryoprotectant risk of all these amalgamation of cells. So that's one of the limitations here. But with slow freezing or even vitrification, that's disadvantage scale has been broken, and it's now possible a treatment protocol to preserve ovarian tissue. And as I mentioned earlier, success has brought more than 200 live births since its inception. And to do the ovarian cryopreservation is a protocol SOP, as I mentioned. You need to take samples from the cortex of the ovary, and then you need to use slow freezing, which is better in a way than vitrification, but you can also use vitrification. There is no difference in outcome between the two processes. The idea is, at the end of it, you want to make sure that you plunge the cryopreserved tissue in liquid nitrogen at -196. And you want to take steps like using cryoprotectant to protect against intracellular or extracellular fluid damage to the cellular components. When we do autotropic transplantation of malignant or of ovarian tissue in cases that are preserving their fertility for future use due to malignancy, cancer, ovarian cancer, breast cancer, we have to deal with risk of malignant cell receding back into the ovary. So there are a number of steps that has been mapped out to guide against this. Either instead of using ovarian tissue, we can use de novo IVM, ex vitro maturation of follicular oocytes, primordial follicles, before we can use them, for IVF treatment. There's also a system where bioengineering artificial ovaries, putting follicles that are derived either from IVM or de novo into implantable fibrin scaffolds. This is then transplanted into the patient. This has been shown to restore menstruation, hormonal milieu in the woman, and it has also, led to pregnancy and live birth. To be able to run a successful cryopreservation strategy, we need a comprehensive protocol to follow. First of all, there has to be a synchronized multidisciplinary infrastructure. It's not a one center do all. Preferably, we have MDT consisting of OBGYN, benign or oncological OBGYN specialist, ART and IVF specialist, counselors, geneticists, pediatricians, specialist nurses, and all the likes. And there has to be a rigorous referral system, which should be encouraged so that when someone is seen that needs to be referred for fertility preservation, that is done promptly, especially if it's related to malignancy in the young individuals or those who are, at higher stage of their malignancy and they need urgent gonadotrophic treatments. Financial sponsorship is also, another, main thing there. As we know, this is a very expensive process. Without good insurance coverage, it might be very difficult for out-of-pocket individuals to access this kind of service. And this service should be, as I mentioned earlier, a joint teamwork. ART specialists, assisted reproductive technology specialists, and oncology specialists using best practice and diligent counseling before starting the process. What are the moral issues to consider, before or during or after cryopreservation? Social responsibility for the whole world. There has to be equity, easy access to fertility preservation. The minor's age needs to be taken into consideration, especially when it involves guardian consenting. And what happens when these minors become of age? We need to reconsent them before we continue the fertility preservation system. We also need to follow social norms, and then we need to think about what process are we going to follow when this involve cross-border fertility preservation centers. Let's say someone has a egg frozen in the United States and wants to bring it into Nigeria. There has to be a lot of cooperation between the two organizations in the two different countries. There has to also be ethical consideration, autonomy, proxy should be avoided as much as possible. informed consent diligently, research and versus medical. We also need to, what do we do with leftover frozen samples that we cannot, or we never contacted the owner of the samples? Should we use them for research, dispose them, or you will keeping them forever? There has to be also some form of legal oversight to avoid any malpractices that will hurt the patients more than the benefits they would derive. There are religious sanctity, to overcome. In some religions, Islam, or even countries that forbid garment cryopreservation, that make it explicit that only married women or men can have access to fertility preservation or even surrogacy. All these ethical issues need to be cornered, and we need to consider when we are talking about fertility preservation. Minor consent is also another very important area to consider. What do we do? What do we do when a minor that needs to urgently freeze her oocytes or his sperm or testicular tissue or sperm because of the need to urgently undergo a gonadotrophic treatment? Guardian of the young girls and boys agreed for fertility, but the patient, him or herself, disagree. How do we, get out of this conundrum? Those are other ethical issues that we should consider. And then when we consent using guardian, minors that agree to freeze their eggs or to freeze their ovarian tissue or testicular tissue, they need to be reconsented when they reach adulthood, what they want to do with the samples stored. And as I mentioned earlier, the male and female pathways, the same in minors tissue cryopreservation, but when they are post-pubertal, we can also use oocytes, embryos, or seminal fluid. But religious issue, as I mentioned, needs to be taken into consideration concerning marital status. How do we store the sample, third-party donors, and then posthumous applications? All this needs to be taken into consideration when we are doing what is the difference between Christianity tolerance compared to Islam, compared to Judaism and Hinduism and other Eastern traditions. What are the real-world outcomes? Fertility preservation is done worldwide and for good reason. However, while data registry around the world are showing patients coming in high numbers to preserve their fertility, especially for planned social cryopreservation, the real world return utilization rates are not matching up with the increased demand to cryopreserve. Most of the samples are left, you can't even trace the owner of the sample. So the conversation now is shifting from preservation to probability of use of the sample you are freezing. And as we can see here, the real world return rate, you freeze the oocytes, embryos, sperm, or ovarian tissue, but only 10 to 15% come back to use the sample. What do you do with 90 or more samples that are left? Do you throw them away, or do you just continue to freeze them forever? And the reason for this low return rate is not far-fetched. There might be life plan changes. Suddenly, somebody that is preserving oocytes or embryos for future use suddenly get pregnant naturally, spontaneously, and they don't need all the cryopreserved oocytes or embryos again. And then they may not even be able to afford paying the monthly fees, charges to keep the samples cryopreserved forever. And then advancing age or illnesses, making them to forget to even go back, to claim or use the cryopreserved organ. So we can see from a number of publications, a number of systemic reviews and meta-analysis, most of them concluding, reaching the same conclusion that the low return rate is, despite, high success rate, but the return utilization rate between 10 and 15% mostly. And oocyte survival rate after thaw has reached 81.4%, even more in some of the centers. And then the clinical pregnancy rate of 34%, live birth rate close to 30% among women who return to use their eggs. And this study followed up the women for about 7 years. So we can see that despite the clear facts that there is success when these tissue or organs or cellular samples are post-thawed, majority of the women are not returning for various life experiences to use this sample. And most of them just lie fallow, and we don't know what to do with them. Oocyte cryopreservation, as I said, return rate is low, only 10 to 15%, due to either spontaneous conception or the changes in life plans. What matters for success in oocyte cryopreservation is egg numbers. For people less than 35, we need 15 to 20 M2s to guarantee 70 to 80% chance of at least one live birth. And in 38 to 40, we need the same number if we can get it, either through multiple stimulation and oocyte collection to give us at least 30 to 40% chance of at least one live birth. So, however, what is discovered in the real world there is that many patients freeze fewer eggs than recommended, either due to cost of the stimulation process or because of low ovarian reserve due to age. So, another study looked at long-term pregnancy outcomes after fertility preservation. As I mentioned earlier on, the long-term fertility preservation outcome is very, very high. And at least we can see that in this study, comprising 26 studies, over 7,000 women, 200 live births were reported. So there are at least some good successes, whether you freeze oocyte, embryo, or ovarian tissue, all producing reassuring long-term benefits. So ovarian tissue cryopreservation, the same, a lot of benefits post-thaw of the tissue and use, either orthotopic or IVM. So a lot of successes, but the post-return utilization rate is all very low. In all these studies, post-utilization return rate is very, very low. How do we manage to keep that up is what is burdening a lot of specialists in this field. Sperm cryopreservation outcomes, excellent long-term viability for decades. We can freeze sperm, and then they've been used at least recently or a few years ago. We had about samples that have been frozen for 55 years, giving birth to life. So those are technological innovations that are keeping, parenthood's need very high. So the real world issues are therefore underutilization, especially after cancer recovery. Most patients some of the patients may not be interested in doing that. They just want to have a good prognosis and good quality of life, not having children when they are not feeling well. And then post-treatment azoospermia makes fertility preservation for men or young adolescents or even boys very critical. We mentioned IVF with ICSI with frozen sperm, the live birth rates with fresh samples are similar. So telling us that there is no little or no deleterious effect by freezing sperm or oocytes or tissue or ovarian tissue. The problem is non-use and opportunity cost once overlooked. And how do we counsel these women or men, adolescents, when they come, so that by the end of the journey, they are not disappointed, they are not dissatisfied, and their conditions are not made worse in terms of psychological benefits of the process they are undergoing. So the issues are non-return for use, storage costs, false reassurance, overestimating success, and late freezing. Someone coming very late, to freeze, either because of cost or because of enlightenment or because they are still hoping, waiting for a miracle to occur. So all this non-use and opportunity cost overload needs to be taken into consideration when we are counseling patients for fertility preservation. Then we should talk about probabilities of success. There should be no promises, because the real world realities confirm very high non-return rate for use. So giving false reassurance that if you can preserve your oocytes or embryos, 100% guarantee, that is a mistake. And then that should not be done, so that at the end of the journey, the patients will not feel very, very angry and dissatisfied. Then we should avoid late freezing. People coming more than 37, 38 years old because of the risk of aneuploidy and because of the low egg yield or oocyte yield at that age. So let's consider this scenario. I put up some ethical flashpoints here. Let's look at ovarian tissue cryopreservation in an 8-year-old leukemic girl. And the risk here that needs to be taken into consideration is no promises to be made. Guardian can give consent. Also applies to this 9-year-old boy with testicular tumor. Guardian will give consent, but when the child reach adulthood, they need to be reconsented. And then the other issue to contend here with will be when you are trying to reimplant those tissue frozen, what are the risks of receding leukemic cells or solid tumor cells in those organs we are orthotopically transplanting back into the owner? So what happens? You freeze embryos without consented agreement, and then something happened to either the man or the woman who can use the gametes or ovarian tissue cryopreserved. And we have seen several examples out there leading to, several months of court trials that end up, with a lot of broken hearts. So we need to, get a very, very agreement or consent that will be applicable even from now till 20 years or 30 years, that we need to settle the agreement who can use the gamete, either after divorce or after death of one of the individuals. Then we also need to consider posthumous use. Someone brain death, but they still want to harvest sperm or oocyte or whatever, or ovarian tissue to freeze. Who can use those gametes or ovarian tissue when the owner is brain dead and gave no consent? So those are ethical flashpoints or conundrums that we need to address. And what happens to those embryos, oocyte, eggs, testicular or ovarian tissue that are abandoned? We cannot see the owner. We cannot get in touch with the owner for ages. What do we do? Do we discard? Do we use them for research? Or we just keep storing the sample forever? Then storage limit. In some countries, you cannot use any tissue or organ or cells that are stored over some quantifiable years, 10 years or something like that. What do we do? Are there legislative laws that back up all these claims of storage limits? So more so in our own environment, Nigeria, where we don't even have any legislative laws or code of practice for ART. Social freezing, we should be very careful. There is no certainty of future birth. Even if you freeze 20 eggs or oocytes for future parenthood, there is no guarantee. Just like we are transferring fresh embryos, there is no guarantee of success. Reimplantation also, it needs to be considered. You don't want to do any risk to the patient. The risk of cancer recurrence and reseeding the body of the owner with cancer cells that have been frozen in the past is also not zero. So fertility preservation by and by and its future, especially when we are considering artificial intelligence and autonomous IVF laboratories. These are cogent, very, very important considerations, and is going to be the future of ART in general. So these are my references. Have time to look at it. They are very, very educative. Thank you for listening. Thank you, FRH, for the opportunity. Thank you, the executives of the FRH, for the opportunity as well to give this webinar. Just to remind you and buttress what Mrs. Sinipi said about call for abstracts and our upcoming AFFS conferences in Abuja in 2026 September, just around the corner. Thank you for listening while we await questions. Over
Thank
to
you. Yes,
yes.
sir. Thank you very much, sir, for your. So thank you very much for your thought on this. It is well understood, and we thank you very much. You have a lot of questions on the Q&A and the chat box, so I will go through some so that you can take them. Are you hearing me, sir?
Yes.
All right. There are some questions that have been raised from the presentation. Meanwhile, thank you for your presentation, sir. The first question from Christopher, he said, if a cells get into a state of animated suspension, a minus 132 degrees Celsius, why do we take the temperature to minus 196 degrees Celsius during vitrification? That's his first question. He has two questions. So should I go ahead and say the two questions so that you take them together?
Yes, yes.
All right. The second question, still by Christopher, says, in the absence of clear regulatory guidelines in Nigeria, what is your opinion? What opinion exists for cryopreserved semen sample that are either abandoned or owner could not be reached? So what are your opinion?
Okay, yes. Yeah, thank you for the questions. The first one is about why don't we just stop at minus 132 degrees centigrade? The reason we cannot stop there because the risk of crystallization is still very high. You are just at the middle of that amorphous solid glass state and the aqueous state. To completely, it's just like if you put water in the fridge. So when the water is completely frozen, you have a solid ice. But when you are taking it out before that stage, you have part water packed ice crystals. So that will be very damaging to the cellular organelles. So the idea is to completely freeze all the intracellular environments, cytoplasm, everything is taken once at a go into the amorphous glass state, rather than you having partial amorphous glass state and then you have the aqueous liquid phase at the same time. This can lead to incalculable damages to the cellular organs, physiology, and metabolic pathways in the cell itself. Whilst the cell is still in animation, but you are in between suspended animation and full animation, which is not advisable. That is can be very damaging. Now, your other question is also very paramount. I mean, we don't have any code of practice, no legislative law backup in Nigeria. What do we do with abandoned samples? Well, it's as simple as saying, before you freeze the sample, you need to take a very, very robust consent that, look, after several months, I have the same in my unit, where we have some samples that are leftovers. We can't trace the owner. What do we do? So, but from seeking legal advice, you have to make sure that when you are signing the consent, you and the owner of the sample agreed, look, this is your monthly fees. You need to be paying either monthly, quarterly, or yearly, or whatever agreement. However, if I don't see your payments for this number of months, we are going to discard the sample. If the owner of the sample agreed, then you are covered. If you agree that after 6 months, no payment, no contact, nothing, we can discard. You may be covered legally, legally, but this can change as per when legislative laws, become available in Nigeria. Thank you.
Okay, so thank you. We have still quite a handful of questions. Another one said, can you further explain open and closed system of cryopreservation? Then another one still on that cryopreservation. If you combine two methods of cryopreservation, does the ratio matter? And what ratio do you use? That's from Ade and Halu.
This this lecture actually should be given by a member of, CIAN embryologists in our midst that are doing this daily, but we can't find any of them to take this topic. So that's why I take it. But it's quite understandable. I mean, we have open system and the closed system. As I mentioned earlier, open system means that when you plunge your cryo device, whether straw or whatever, you are not closing the bottle or you are not sealing the straw. You are just putting it like that. The benefit of it is that your sample, your oocyte, your sperm will come directly in contact with the liquid nitrogen. And what this means is that it can crash the temperature of those organelles, of those cellular, of those cells from 192 straight to 196, giving little time for any ice crystals, extracellular or intracellular, to develop that can damage your cells. So, however, when you don't close those samples, there is a theoretical risk. Some believe is not theoretical, that is real. That viruses, bacteria, fungi that are inherently present in the liquid nitrogen can contaminate your sample and giving rise to infection transmission, or can even give rise to the death, to apoptosis of those cells you are freezing. So that if you have an open system where liquid nitrogen can seep into your cryo device and get in direct contact with your cellular tissue or organelles, and then can cause a lot of damage or infection transmission. However, if you close the system, if you have like what we use in the valves we use for sperm, we close it when we are dropping the samples in liquid nitrogen. This avoids direct contact between your sample and the liquid nitrogen, thereby eliminating the risk of infection transmission to the samples you are freezing. However, the rate of temperature drop, even when you plunge the sample into liquid nitrogen, is very, very low compared to the open system where the liquid nitrogen comes into direct contact with the cells. That can create the kind of condition I answered earlier. That is part amorphous glass, part liquid intracellularly, which can cause a lot of apoptotic damages to the cells. So when you post-store, your success retrieval of live cellular tissue or organs are not very, very encouraging. So closed system, you close it, avoiding direct contact with liquid nitrogen. Open system is open, no sealing, no cover. Liquid nitrogen have easy access to the cells. They both have their advantages and disadvantages, as I mentioned. Thank you.
Thank you, sir. The last question from Odinga said, I think some of them are comments to what you have shared. She said the cryopreservation consent form must be very carefully drafted and counseling professionally, and there should be a solid and separate cryopreservation contract from what should happen if the owner fails to pay or stay in contact. Most clinics have only cryopreservation consent form, which is inadequate. She also talked about that. Are you aware that cryopreservation is covered by existing contract law, and the clinician can avail of them by using a well-drafted cryopreservation contract? Then her last comment is that posthumous conception is already partially covered by the National Health Act, but the problem is that clinicians do not satisfy the requirement. The consent form can serve as a will if the process is managed according to the relevant provision of the National Health Act. I think those are the questions and comments that we have on the Q&A section. Thank you, sir, for your excellent presentation.
Thank you for your comments.
Yes, sir. I hand over to Onipi for closing remarks. Thank you very much.
You're welcome.
Onipi Samuel, thank you.
Okay, thank you, sir. We extend our sincere appreciation to you for your valuable presentation. It's been 3 sessions back to back, and you've been providing us with in-depth perspective on current fertility strategies and their clinical outcome. Of course, it's greatly enriching us, the participants, and then in our knowledge-based understanding of this important aspect of reproductive medicine. Again, we say a big thank you, sir. And also, we extend our heartfelt appreciation to everyone who has been a dedicated participant in our bi-monthly webinar series on embryology. Your consistent engagement, enthusiasm, and commitment to advancing knowledge in embryology have been instrumental in the success of this series. We sincerely value your participation, and we look forward to your continued support in future sessions. And for the forthcoming conference, like I always say, the second Congress of the African Federation of Fertility Society, FFS, alongside the 16th Annual International Conference of the Association of Fertility and Reproductive Health, AFRH, tagged AFFS Abuja 2026, is slated to take place on the 24th to 26th of September 2026, and the theme is Fertility Frontiers, Global Innovation and Advances in Human Reproduction. The venue still remains Abuja Continental Hotel, FCT, Abuja, Nigeria. Of course, participants who are looking forward to still register, www.affsconference2026.org is a website too. And of course, the good news I shared earlier is the abstract submission for AFFS conference has been extended to the 15th of July, 2026. So don't miss this opportunity to present your research and contribute to advancing fertility care across Africa. Exciting prizes await the best abstract submission. So for the submission of abstract, the guidelines, please visit the AFFS conference 2026.org/abstract, and you'll find the instructions there. So we also encourage everyone to download the AFRH Nigeria app. No need to search the App Store. Simply install it directly via visit.app.afrhnigeria.org/install. Please note, like I earlier stated, that this session has been recorded and will be available for playback on the AFRH website. Do follow AFRH on all our social media platforms, as shown on the screen, for updates and announcements. The new date for the commencement of the next webinar series will be communicated in due time. Until then, I remain Inikpe Uja Samuel. Thank you all. Over to you, Mrs. Alana.
And thank you very much. Thank you, sir, for your presentation. And thank you, all listeners. Thank you. I think the webinar has ended.
Thank you. Bye.
Thank
Thanks
you.
for
Goodbye,
coming.
everybody. Bye.
Bye.